Okay, thanks, Dr. Anand. Hi, I'm Raj here. I'm a trauma and vascular surgeon from Singapore, and I'll just be bringing forward a few questions in this segment to our speakers based on some questions which have come through the chat, as well as some questions that have been transmitted directly to us by the audience as well. So perhaps if I could just perhaps target my first question at Dr. Irene. And thanks so much for that wonderful talk and that very descriptive session on what exactly you were facing on the ground. I wanted to ask a question which is a bit related to some of the other topics as well. It's a question that's come in regarding contingency plans when we create, whether they were contingency plans that we had in preparation for an attack in the hospital itself, because that's not something that we usually prepare for. Most of the time, we prepare for attacks, large numbers of patients entering the hospital, but very rarely do we prepare for in-hospital attacks. And I'm just wondering whether after this incident in Marawi, whether there were further efforts to build such plans within your hospital system.
Well, as mentioned by Dr. Guru earlier, hearing gunshots are not new for us living in Marawi. So we usually have plans in place for such events to occur. But the scale and the magnitude of the attacks that happened at that time really overwhelmed the resources. And the instinct of the staff who were in the hospital was to flee and keep the family safe. That's why a group of doctors came back to run the plan or to institute the plan that was already formed before. But again, the odds were against them because most of the staff left already. So only a few of them were remained in the hospital to attend to the victims of the siege. That's why the Department of Health decided to close down the hospital and just cater to those victims of the siege.
Thanks, Dr. Irene. Thanks a lot. There was a further follow-up question from you from Dr. Sandy English in the audience, asking about emergency medicine specialists as part of your acute hospital team and how your hospital system was structured with regards to surgeons and emergency physicians as well.
At present, the head of the emergency room at May Pakpak is a surgeon. So we don't have practicing emergency physicians at the moment, but the Department of Health is trying to establish trauma centers in different strategic regions in the country, and hopefully we will have staff which includes the emergency physicians in the future.
Dr. Irene, you've answered most of the questions which were there and which Raj also posed, and I think it was a sad incident, obviously, but a lot of grit and determination showed by the healthcare professionals also, because the hospital itself became the victim of the armed conflict. And as Dr. Raj actually said, are there now drills going on in those hospitals, not only in that region, but you said there were a lot of training programs you had started as a result of the siege and the health aftermaths thereafter. Are the drills continuing from 2017 onwards, and what's the frequency? Because the reaction of even Colonel Pawan Sharma, sort of highlighted that regular large drills, including administrators, including the police, and maybe armed forces in such areas is also a must. So are they continuing? Just a question.
Yes, we're trying to make the trainings as often as possible, especially the drills and the training of the staff. But admittedly, one of the hurdles is the availability of the resources to conduct such trainings.
Yeah, absolutely. I mean, I can understand, we are ourselves a resource-stretched country, and our massive landmass in India also, precludes us from doing very large scale drills. But then I'll come on to any other question, Dr. Raj. I think first we'll ask those questions which are already there on the list, and then probably go on to asking some more questions.
Thank you. We had another question which actually came in for Dr. Amir, and this was actually with regards to the conduct of exercises, in particular focusing on processes versus clinical management itself. And do you find that in these mass casualty incident training, that the focus really should be on workflows and trying to get people where they need to be, rather than testing them on actual clinical management? Or is there a specific role for that, or should it be done together?
Thank you for the question. I think that question was actually answered by Dr. Bala, saying that a mass casualty incident is not a medical problem, it's a logistic problem. Within the training curriculum, we assume that people who are going to work on the field are professionals. They know what they need to do. It's like eating food, you need fork and spoon. So what you need to know is how do you act when it is a scarce situation, and the training teach you how to collaborate with other organizations, and also how you can build up a team, because you cannot manage everything by yourself. I think the other speakers has also brought about the ethical, medical decision-making, and also legal issues that we are encountered when we are going to have a disaster or mass casualty incident management. And these are the things that we can pick up and train people about. So yes, we can go deep into the medical issue. I'll show you some picture from MRMI to discuss the operation and the way we can manage the people. But basically, we have organizational issue that can be taken care of by 3LC and MRI, and also we can go deep in the triage and treatment of the patient.
Thank you, Dr.
Right, I'm seeing Dr. Harboza's hand going up. I think he wants to respond to some points made by Dr. Khurram.
Yes, thank you. Those exactly the points I'd like to raise is the fact that what I believe over the years is that not all surgeons are designed to handle mass casualty incidents, and you need to have a specific type of surgeon that actually knows how to work in a resource-limited environments. And what I used to do with my young surgeons was to bring them with me to remote islands in the Philippines and do what we call surgical missions. We do rural surgery, and I see how they respond in operating rooms or operating theaters where the resource situation is entirely different from the resources you have at the medical center. Then I have an idea of who are the ones that actually know how to improvise, innovate, and make decisions, because that's I think the difference of working in mass casualty incidents. You've got to think on your feet, and it cannot follow a specific protocol because everything is based on experience, judgment, triage, etc. So you need to create that level of what we call this attitude. It's an attitude that needs to be developed among young surgeons, military. I think the military surgeons have this. I think when Joel Macalino showed that way forward medical team doing all of that pre-hospital, that takes a level of attitude to be able to do that. Thank you.
Just a comment to what you say, if I may, is that my first surgical mentor told something that I have in my mind all my life, and it is a great surgeon is not the one who operates, is the one who say, I do not operate, because of the different issue that involved that surgical procedure.
That's correct. That's very hard to do in a mass casualty incident. When you say, I can save this guy on a usual day, but not today. I'm not going to do this today. And that takes wisdom. Thank you. Thank you for saying that.
Thank you. Thank you, Dr. Khurram and Dr. Teddy.
Yeah, Raj, please continue. Yeah.
Sure. On a related note, and this is a question actually for Dr. Bala. When you had shown quite a few pictures of drills and exercises being done at Hadassah, and I'm just wondering how, on a practical note, how do you run these exercises parallel to your peacetime processes within your hospital without disrupting care too much? Or do you shut down for most of your peacetime activity to run these mass scale drills and exercises within your hospital?
Thank you for a question. We are planning the exercises in advance. It's often, if it's planned, it's corrected by the big boss, I say, conference authorities. They would send us the scenario and check that how we are doing an exercise. It often take about an hour. You have to plan in advance. So we are not stopping any activity at hospital, but it does disrupt the action of the emergency department for a certain period of time. Often the exercises are short. I don't remember anyone that lasted more than an hour. And you have to train the pieces of the mass casualty issues. For example, today or tomorrow, we're going to train the administrative part, and then we're going to train the management of the patients through the imaging department and see how do they collaborate with the rest of the hospital. And then the big drills are really should be planned in advance about few months. We're going to have a drill, for example, in the middle of April, and I already been in the process of planning stuff in advance to make it less annoying for the patients that should receive care in the hospital. And technically, it's not that difficult if people are interested in training, and it's part of the process that we're trying to implement in any hospital, actually. So not that bad.
Thanks, Dr. Bala. And I think I really appreciate the point about doing small scale exercises as well in different components and then bringing it all back together. And I think that's a great model for a lot of us to follow. For Dr. Amit, just one last question I have for Dr. Daniel, actually. And this comes with regards to some of when we talk about different standards of care in a mass casualty situation or major incident situation, in your experience and in the literature, what are the medical legal aspects here then thereafter? And are there any medical legal aspects which a hospital or providers have to be aware of, especially as we get into a more litigious world and where there's a lot more legal activity going on? Are minimum standards of care in a mass casualty an acceptable defense in your experience?
Well, thank you for the question. I cannot really talk of experience because I'm an ethicist and I'm not working as a medical or a legal advisor, so as an ethical advisor. So I can answer from an ethical perspective. And I think if you're confronted with a situation where you have not enough resources, and I like the example given about the island, because there you have less resources than you're used to. So this is kind of resource scarcity already. So in situations like this, what you have to do and what your criterion has to be is to do the best possible with what you have. And when you then have to lower the standards of care, nobody can in the end say you should have done better because that was the best that you could do in the situation. So the best surgeon cannot operate if there is no, if he doesn't have the means. The best anesthesiologist cannot do a proper anesthesia without the means. So you have to do with what you have. And if then it's the best that you could do in the situation, then I think ethically it's still the best you could do. And I don't think that there will be any legal consequences that you have to fear. I mean, maybe you have to inform patients. That's what I was talking with informed consent. Maybe you have to inform them that this is not the best you could offer with other options, but the best you can offer now. So maybe this is something you have to do from a legal perspective.
Thank you. Dr. Bala?
I just want to emphasize some things that related to the last question and also the one before. So the role of the surgeons in a mass casualty incident, it's in the beginning when we start management plan in hospital country-wise, it was based on surgical issues, and the surgeons took part as the leaders. And now it's a little bit different because we want to spare our surgical, ability to take care of casualties and give the hand to others who may, for example, emergency physician, who are able to manage the mass casualty incident, not that even better probably than we are. And that's why in the last casualties, the real one, last disasters, the surgeons actually were used in what they should to be in the trauma room, in the operating theater. And from the ethical perspective point, I think that if you have enough resources, the care for the casualties in the mass casualty scenario is probably the same as for the single patient. It's really happened very rare that you have some patient that you have to, accept the minimal care or no care. But it's seriously, I don't remember last, 15 years, something like that happened. Thank you.
Thank you, Dr. Bala.
Yeah, thank you, Raj. We'll come back to the same question. I think Dr. Bala and Dr. Milkosh, and probably the ethical question Dr. Makalina can also, answer, is that Dr. Milkosh said that the processes of care are more important than the actual care, because we all know as doctors what to do as a surgeon, as an anesthetist, as an emergency physician. I saw that when I went to Israel, to Rambam, for the international MCI course, and was trained by Moshe Michelson and Gila Hyams there. And I saw most of the hospitals all over Israel. It being a smaller, country as compared to, say, India. What I wanted to, express and also elicit from you is that in a wider country, or in a country of multiple islands like Philippines, I think it's better to have regional systems rather than a federal big system. Obviously, a federal big authority is definitely wanted to publish guidelines and guidelines on process of care. But I still firmly believe that regionalization of emergency medical systems, I would say, or mass casualty systems, is more apt for bigger countries rather than having a single incident command or command and control system. So what are your thoughts on that, Dr. Milkosh? Then I'll come on to the ethics part to Dr. Makalina.
Thank you. As I understand, you asked actually what's the better plan system for country-wise. So in our place, it works definitely different than other places because of the, as we said, integrated military and civilian, and then the legal authorities are the same for all country. But I think when the big countries like India, like Philippines, and I think they have to have some regional plans that answer the certain question for a certain region, because if you have an islands, probably it should be different than the one plan for the major city, for example. So evacuation is different. The hospital are less maybe equipped and have less resources. It should be the standards should be the same, but the plan for a certain region should be different. And that's why we are sitting here in this big conference and trying to figure out what the experience of each other's and how we can complete how we can cope with the mass casualty incidents of disasters based on experience of each other.
Thank you, Dr. Milkosh. I think a question to Dr. Amir also, because he dwelled upon the training aspects of mass casualty incidents. Do you prefer more administrators or a batch of 50-50? I mean, what would you say would be ideal if a batch from a given hospital is coming to you for training in mass casualty incidents, as Dr. Milkosh already said, and most of the panelists also agree, that it should be a good mixture of both administrators and surgeons and emergency physicians, or maybe even paramedics and nursing. Would you suggest that it should be given to different people at different times, or maybe a single course can be given to the whole team, so that the administrators also understand under what conditions do the clinicians work, and what would be a rough ratio in your head? Sort of what would you, sort of propagate or tell us?
Thank you for the question. But first of all, I must say that what we train people beside the medical knowledge is how to collaborate. And collaboration does not mean that you can get more staff or personnel, but you actually appreciate what you have. And that also means that two partners need to realize what kind of limitations and abilities they have. So we do not ask people to give us something that they actually don't have. That also indicate that we need to have not only local preparedness, but also regional preparedness, because we need to substitute not only the staff, but also we need to collaborate. So bringing someone to an area that needs really a staff and structures will be very hard if they do not understand the local knowledge and local understanding of the situation. So that will be implied in all training courses, because they need to realize each other's responsibility and how to act.
Right. Thank you, Dr. Amir. I think one question which I had in mind, if there are no questions on the chat panel, is to Dr. Marcelino, because he was the one who actually analyzed the whole Marawi incident as an ethical issue. And he also is an attorney, so in addition to being a surgeon, so it's a very unique combination. So I just wanted to ask you, I mean, obviously there are no ethical wars, especially in today's world where terrorism or non-state actors, obviously supported by some people with their own interests, would say wage a war, a covert war on state actors or the military or the police. In these situations, would you say that the ethical issues remain just ethical? And you raised a very nice point where you yourself said that the military doctors were who are also partly trained in armed this thing were actually carrying arms all those 5 months or 4 months, not only probably for their own defense, but probably also with a view that they might act otherwise if need be. So would you say that this is the need of the hour, and it becomes ethical if the state actors are acting against unprovoked sort of conflict raised by non-state actors? What was the thinking going on in the Philippines actually regarding that?
Well, yes, I left two questions for Dr. Meselken. Mainly, number one, are the medical corps or are the people in charge of the medics is it ethical for them to carry firearms, showing that what they were carrying is more than that of the regular M16 that the Philippine military or the soldiers are carrying. So I asked that question to the major who was the head of the medical team, and he said that well, it was for defense. The armaments that they were using were for defense. And that my second question was that of will they treat enemy combatants if they encounter them in the field? The major actually mentioned that they were able to treat a lot of enemy combatants, only that after their treatment they were considered prisoners of war. So I think those are the still ethical issues regarding that, and I have no answer for that except for the realities on the ground. And earlier, there were questions as regards to the certain medico-legal aspects regarding what is termed here as in the Philippines, we have the what is called the emergency rule. That emergency rule is that of what you call reflective thought, that after some time, when you are not given an opportunity to think about it more clearly, to consider your options because it was an emergency situation, such a reflective thought will be not punished, or you are not liable or entirely liable for that. So that has been upheld by our own Supreme Court in a lot of cases. That is usually called here emergency rule or reflective thought doctrine. Thank you.
Thank you, Dr. Markel. Before I go to Dr. Amir, who has raised his hand, I want to go to Colonel Pawan Sharma, who has remained in the areas of conflict in India for a very long time. He's an army surgeon, and at the same time, he went to the far north areas where a sort of perennial conflict is going on in India. Colonel Pawan Sharma, your views or your experiences vis-a-vis the Marawi siege, because most of your area of work was perennially under siege. It is even today. So would you allow doctors in Indian Army to go with arms, or there are other issues?
Yeah, thank you, Professor Ahmed. It's a very, very pertinent question as far as armed forces doctors are concerned. I'm not very sure about other countries' armed forces, but as far as I know of IDF or US Army or UK Army, and of course Indian Armed Forces, our armed forces medical services are raised with a dual role. We are both soldiers as well as doctors. I had this experience of serving in one of the highest battleground of the world, that is the Siachen Glacier, in the early days, and later in the Kargil War, where I was the battalion medical officer. And of course, as recent as just 2 years back in the northern sector of the Indian state of Jammu and Kashmir. So we actually, during Kargil War, that was way back in 1999, we were faced with both the challenges Professor Amit just brought out. I was the doctor with, we call it RMO, or the regimental medical officer, with one of the fighting battalion in the forefront. And we are, in fact, as a mandate, we are issued the licensed firearms as a self-protection, if need be, because you'll be able to provide care only if you are alive. So if need be, if you are overrun, you are very much authorized to use your firearms against the enemy. And of course, you need to protect your piece of land and protect your people around you. And in that case, when it becomes a life-threatening situation, you are very much permitted to use your firearm. And later, once the situation improves, maybe then you switch your role as a doctor or as a surgeon. And the second question of the enemy casualties, yes, that is another, in fact, ethically very relevant situation. We had 4 of the Northern Light Infantry soldiers of our neighbors who were fighting against us during that off Vijay. And in that Kargil military hospital, we had a small 20-bedded hospital there. Our soldier captured 4 of those wounded soldiers when they conquered the enemy post. And these 4 wounded enemy soldiers were brought to our hospital. And in fact, we treated them at par with our soldiers. We didn't discriminate against their treatment in terms of urgency or on the medicines or the required surgery. And later, of course, they were handed over to the intelligence agencies after adequate initial treatment. So ethically, we are bound to treat both as per Geneva Conventions, as per international norms. Both are your own soldier as well as enemy soldiers. And of course, you are in fact, it's very pertinent to use firearms if the need arises. Thank you so much.
Thank you, Colonel Pawan. Actually, what my also interest was to know, like the conflicts you mentioned were declared wars. So, and therefore the Geneva Convention comes in. But there are so many conflicts world over going on where non-state actors are declaring undeclared sort of war against, and that's what we call terrorism. Now, in those situations, when a siege happens, what do doctors do? That's again ethical dilemma, which probably I'll leave the audience with. Dr. Amir has his hand raised for a long time. Dr. Amir.
Yeah, I was going to comment some issue when it comes to ethical viewpoint. We had a publication regarding hospital evacuation, and in that, in 2017, we asked for ethical guidelines and ethical viewpoints before hospital evacuation. It's interesting to know that 2 of 15 countries we investigated, only 2 countries had ethical guidelines, and the rest of them, they didn't have any ethical guidelines. Some of them, they never thought about that, actually. Recently, we also looked to how military and civilian professionals view the ethical cases. So we had a research paper where we introduced 6 different ethical incidents or ethical issues and asked them to decide what to do in that ethical situation. It is interesting to know that both civilian and military professionals actually denied to follow order or any other kind of recommendation and actually went for their own judgment. So what I'm trying to say is that the world is changing. What we believe it was real for 10, 15 years ago, maybe it's not the real thing in 2 years. So we need to look at ethical issues much more and bring it up, as Daniel said already.
Thank you, Dr. Amir. And I think we are heading for the time for the open session. But before that, I would pass on the buck to Dr. Daniel, because his hands were raised. He wants to make a quick point, and then probably we'll close the open session.
Okay, thank you. I will try to make a quick point and to react to the 2 questions asked to me by Dr. Macalino as well. So the first one that we were just discussing was about carrying arms. So I think it's from an ethical perspective and from a legal perspective, looking both into the Geneva Conventions and customary law, it's okay to carry light weapons and to use them in self-defense. I think problems arise when you plan as a military commander that the doctor is carrying a weapon and can participate in the fighting as well, because then it's not self-defense anymore. Then it becomes at least something in between. And the other problem that comes with doctors carrying weapons is that they become a legitimate target. And doctors are a scarce resource as well. So you should rather protect your doctors and not put them in the first line, because when they get killed, it's quite difficult to replace them, and you need them to treat the wounded. And then the second question, should you treat enemy combatants? Well, I think from an ethical perspective, there's only a clear yes to this, because the moment they are wounded, they are no longer enemies. They are wounded human beings, and they should get the treatment, and you're not the judge. So I think the correct thing is to treat them and then to take them as prisoners of war. Of course, yeah. And all of this, I think, amounts to the question of how we should react to unethical behavior from others or to unethical modes of warfare. And I think that the problem that we have here is that we want to uphold our ethical values, that we should still act according to ethical principles, even if the others do not respect them, because they're not acting ethically does not give us a justification to do the same. I think, and the same is true for legal values, for legal regulations as well. So thank you.
Thank you, Daniel.
Dr. Amin, just one last comment by Dr. Teddy. I think he wanted to mention something as well about ethics as well. Go ahead, Dr. Teddy.
I was about to ask him. Yeah.
Actually, I wanted to ask an ethical question. That was my request, because when Typhoon Haiyan hit the Philippines in 2013, it hit a portion of our Philippine islands that had the weakest health systems. They were so weak that the mortality rates, maternal mortality rates were high, vaccination rates of children, the immunization rates were low. and the health status of the population was poor. But because of the overwhelming response of the international community, I think I had over 180 medical teams from worldwide that came in and helped us. We had a situation in that particular area of the Philippines wherein the ratio of doctors to the population became better, and there were operating rooms, field hospitals were set up by different countries, and the people had very good healthcare. Normal delivery, cesarean section, orthopedic surgeons, neurosurgeons were all there. Now, that's not an ethical issue. The ethical issue was when they left. So suddenly there's another vacuum again. So I'd like to ask this question to Daniel. And that's from the point of view, not from the physicians or the surgeons. It's from the point of view of the people who find, what did you do to us, right? So Daniel, what are your thoughts on that kind of a situation?
Yeah, I mean, if I understood the situation correct, I mean, then the question is, what do you do if you take away the healthcare that you bring in and reduce to the usual level that you had before? I mean, that's of course not a very fair thing to do, because what you get in an emergency, if what you get in an emergency situation is actually better than what you can get in a non-emergency situation, then I think something is wrong with the distribution of resources in a non-emergency situation. Although probably in this specific example you gave, a lot of the help that came in maybe was international or was sponsored internationally, so it was not the same resources that were used in that context. But yeah, I mean, it shows very well that resource distribution is maybe even more than a local problem. It's a global issue in the end, and yeah, we should all do more to raise the level of healthcare all over the world to an acceptable level, at least.
Thank you so much, everybody. Thanks, Dr. Irene, Dr. Amir, Dr. Melkosh, Dr. Daniel, our wonderful speakers of the evening. Thanks to the reactors, Dr. Mahanama, Dr. Pawan Sharma, Dr. Teddy Arboza, and Dr. Joel Macalino. And thanks to our moderators of the day, Dr. Ronnie Torres and Dr. Anand Katyar. I'll bring the open session to a close now.